don't even know. I don't know. I'll be honest, I haven't even looked at it, because I thought it started at 1:30. I mean,
Yeah, it starts at 1:30.
I'll get there a little early and see, I don't know. Yeah, I'm not sure.
Good, we clean, no, he didn't, Bob didn't run.
Technology, my good friend Mike Farley, mainly getting this together, and of course we thank and the is and I hope this will be of a being us together. Not a virtual days, is it? It's really not. And secondly, I'm just very pleased to say we welcome back for thank you with us. Forgive me.
Sorry, Alexicos, but that's okay. I've had worse.
Yeah, well, you don't deserve it because you are one of our heroes.
Oh, thank you.
His boss, Anna, know the heart and soul of the public health. And these are the people who've been working their tails off. So you work your tails off all the time, but it's been 9 months almost now for the COVID. And you've had to deal with so many things to try and keep all the people of New Hampshire safe and deal with changing guidance from, federal, state, different conditions as things change. And here we are in a time of great optimism because we have vaccines that are apparently on the edge of being approved as being both safe and effective. News. But at the same time, we're having this, I don't know what you'd call this, a second or third wave, but it's certainly another surge in this deadly virus. And now we are dealing with, even more shutdowns. We're beginning to see signs of supply chain interruptions and people beginning to do maybe some panic buying like we had back in March. Gosh, I hope not. That was pretty dreadful. Mm-hmm. So I think you're the right guy to join us, Phil, and tell us how things look to you now after wrestling with the demons that you've had to wrestle with for 9 months. And so welcome back. And what do you think? What do things look like now? What are the chief problems you're working on? And and how are people responding at this time when we're all getting pretty sick and tired of dealing with this virus?
Yeah, it's definitely been an experience, that we'll put it that way. We had the sort of, steady, quick ramp up early back in March and into April, and then really had a lot of our hospital surge sort of lagging the case spikes, which it typically does. There's usually different indicators that we use to measure community transmission, risk to the public, but also the severity of the illness. And we continually learn new things about infectivity, immunity, what works best. I think everybody needs to be mindful that there's no one strategy that is going to solve this crisis. And I think we can often hope for, that magic bullet, if you will, silver bullet to, take care of the problem. But it really takes a multi-layered approach. I've heard the euphemism used of a layered approach. I like to think of it as taking pieces of Swiss cheese and layering them on top of one another. So you have the first line of defense is a mask or a face covering, and certainly that's been discussed in many venues and forums, and I'm not going to get political, but essentially a mask is a protective measure, and it protects the person wearing the mask, but it's more important for protecting others from you. We know that viruses are small particles that can travel through, cloth and other materials, and people will point to that as well. It's not that effective, but it is effective when those droplets are being blocked close to the mouth. And viruses are usually stuck to other particles like saliva, and those are big. So those are likely to get trapped, in a mask scenario. So you are reducing the ability for whatever's coming out of your mouth to become an aerosol get suspended in the air, get distributed on surfaces. So that mask is really an important barrier.
I'm really glad that you brought up that one particular detail about the size of the particles that we're talking about, because I can't tell you how many times people have told me what an idiot I am, because how can I possibly think that a microscopic virus is going to be stopped by cotton cloth, even if it is 2 or 3 layers? And I try to point out to them, the virus itself is not floating around independent of these tiny droplets that we can't see, but that are big enough that cloth can stop them. And that's the other argument when I say, well, it's the droplets, and they say, well, you'd see if people were spitting. It's in between those sizes, correct?
Yeah, I mean, you are going to stop, those larger particles, and that does reduce the viral load, if you will, into the environment. Granted, if you're coughing, severely coughing, and you're really generating particles of all sizes, yes, some of those are going to get out. So it becomes really important that we use that layered approach. So, doing employee screenings at the workplace, it's not just having a fever. I think a lot of people will get hung up on, do I have a fever? Yes or no? Well, I don't have COVID if I don't have a fever. There's a whole cadre of symptoms that mimic and mirror what we might experience with allergies or common cold or other respiratory infections. And that's why we've taken a very aggressive approach to say, if you are having symptoms that you can't otherwise explain, because some people have seasonal allergies, and that would be explained if you're experiencing similar symptoms, or if somebody has a chronic condition that it may mirror their typical daily baseline, that may be a symptom, but it's not a new symptom. So we have to be mindful of that. So that screening is taking the I'm coughing a lot and creating aerosol out of the equation, coupled with the use of a face covering. Those are 2 of those layers. And then the third layer, that's one of the more important layers, is that of distance. So you have face covering, you have screening, you have distance. And when we look at people who are known cases, positive cases of COVID, and remember, up to 40% of people that are positive and infectious are asymptomatic.
That's the other part.
Yeah,
They'll get by screening, right? I mean, you can do all the screening in the world, but an asymptomatic person is still going to be there. So that's why the mask, and that's why the distancing, right?
Absolutely. They cannot be done independent of one another. So you add that distance piece, and again, you have particles that are coming out, and hopefully they're not, generated in a way that they create a persistent, smaller particle aerosol that's going to stay in the air. So if you stop it at the source, and then that's very, very effective in reducing the amount of aerosol that could be infectious. That 6-foot distance is helpful in general. There's nothing magical about 6 feet, other than we don't believe at this time that if you are closer than 6 feet for 10 minutes, you are considered a close contact, and you would be subject to quarantine. If you design workflows and classrooms and other venues to put the seats more than 6 feet apart, and face coverings and screenings, you are reducing the potential spread by having multiple protective factors in play. So we really stress to folks that as we sort of shifted back to, in-person work for a lot of folks, or, different, community activities, they had to be reinstituted with COVID prevention in mind. And for a while, we did a very good job sticking to the guidelines, social distancing. And then during the summer, of course, we're outside more. So there's less time spent indoors where the air is not as, it doesn't circulate as much. You don't have fresh air available to dilute, the air supply to reduce any viral burden in that space. And now, as we sort of expected to see some semblance of a resurgence, if you will, because people are now indoors more, we do, and I will say that this is a real phenomenon of COVID fatigue. As you mentioned at the outset, we are all more than tired of of having to deal with this because it's impacting our lives such that they aren't the same lives that we lived before. So I will say that, while face covering use is generally pretty good, we certainly need everybody to do it. But on the other hand, I think folks have really changed their mindset of what is a safe, risky activity and what is less risky or more risky. And what I mean by that is, in the course of our investigations, we ask a whole cadre of different questions about who are your close contacts. So we will ask somebody to identify anybody who they believe was within 6 feet for more than 10 minutes cumulative of them. So they will self-identify who a contact is, but we also will work with the workplace to figure out if there are other people that maybe the index case or the case didn't identify. So we try really hard to figure out it's both social and work close contacts, so we can get a hold of them and let them know that they need to quarantine because they've had a close exposure. But I think what we've found in the last month or so in talking with people, the types of events and activities that we are seeing more and more of in terms of multiple people being positive. Obviously, you have close family members in a household unit, which you would expect, but also people having gatherings in the home setting or with friends that they trust. Because people can be asymptomatic, just because you host a few people at your house is your kind of safe space. Sometimes we let our guard down and we may not do social distancing as well, or not wear our face coverings in our homes. And that is leading to experiences where people are less vigilant, and then other folks are becoming infected as a result of some of those types of events. So we really want to pay very close attention right now. Obviously, this is the holiday season, and that is family time for most people, and we need to make sure that we have the right information about making informed decisions about what's riskier and what is less risky. and I've heard a lot of misconception or kind of misunderstanding or false sense of security around testing, and so we have more testing available to us than we did probably the last time that I spoke. But what folks are thinking about when they're testing themselves prior to travel, and we don't recommend travel, other than within New England or day travel. The more common carriers like boats and planes and buses and trains that people get on, that ratchets up the level of risk. But we also have to think about who we're visiting. If we're visiting anybody who is over the age of 65 or older, we know that those folks have greater or poorer health outcomes related to infections than the general population. We don't necessarily know everybody's medical history that we might be wanting to get together with either. So if I'm, going to an event or a gathering, if I don't have social distancing and face covering in my playbook, then that is a risky environment, especially indoors. And getting a test before you travel is helpful in the sense that if you're positive, we're going to know you're positive, and you're going to need to isolate, and then hopefully you won't travel. But if you're negative, that doesn't mean that your body may have had an exposure within the first few days, and then by the time you travel and then visit, you could be infectious, and if you were to take another test, you might be positive. And so there are circumstances where you get a negative test, I think I'm all clear to do whatever I need to do, but that is not a foolproof strategy. So people need to know that.
That's a snapshot in time.
Yes.
And in fact, the way these tests work, I'm not a scientist, and please correct me if I'm wrong,
Sure.
but
Yeah.
you can have been exposed and be infected, but not have enough of a viral load that it's detected. So you walk out of that test thinking that you're negative, and then as the days go on, your viral load is increasing. Am I getting the mechanism right?
That is correct.
So you think you're safe as a baby, but in fact you're a typhoid Mary.
Yeah, you can't be sure when you have a negative test that is a snapshot in time that you may have had an exposure 1 or 2 days prior, and your body just hasn't either generated enough virus or viral material, DNA, or other proteins to be detected by either a rapid test or a PCR test. And those two tests are different. The PCR test is right now our gold standard, is that it's able to detect evidence of the virus sooner than the rapid test. And the rapid test, while good, are most effective when you actually have symptoms, and that you've had those symptoms usually for 2 days prior. So to your point, being able to have enough of viral material in order to trigger a positive test. So getting a rapid test, while convenient, if you don't have symptoms, for some of the tests, it's up to a 15% false negative rate, meaning, to your point, you have a negative test, but you could still be in that very early stage. Yeah. So I think as people make decisions, ultimately we would want them to stay within their immediate family structure, but you really have to think about who you're visiting and do you want to put them at increased risk. Yeah. And we know in our community, we are seeing activity that rivals the very early stages of COVID. And what's different with the data now than back when we first started ramping up testing is when we first started testing folks, we were only really testing people who were symptomatic. And so by knowing that people that we're testing are asymptomatic and are positive, that just gives you an idea that there's a lot of people out there that maybe don't know that they're potentially infectious, and that community-wide spread. And we're looking at several indicators. We're looking at case numbers. We look at case numbers over time, because depending on laboratory reporting and other phenomenon, you may have blips. So we could have 10 one day and 40 the next day. But over the last 14 days, a running average, if you will, our case rate per 100,000 is over 26. And that is the highest case rate that we've had since this started. And the school board met on Monday night, as you might know, and based on metrics that we provided to them, which include mitigation factors like our ability to contact trace in a prompt manner, and also different structures within the community for protection factors and hospital admissions and things of that nature. The amount of cases that we're seeing over a 14-day period by the end of this week would put us into 14 days of red, which for us is evidence of strong community transmission, in the sense that it's as high as it's been since last March and April, when we first started getting into tracking. So we are definitely experiencing what we would call the second surge, and it is impactful.
It feels that way, Phil. Just in my own personal experience, I'm hearing more and more of people that I'm acquainted with testing positive, or having someone in their household testing positive. It's like it feels closer than it did even when we were really kind of panicking back in March and April, when we didn't know what this was. And I think everybody's got a kind of a better perspective of what these rates really mean in their life. They were just numbers before, and they sounded very scary. But now we see, what does that really mean in your immediate life? But like I said, I'm seeing, folks that have to stay out of work because someone in their house has tested positive. So we have to keep them away for the quarantine period,
I just wanted to say, Phil, you've talked so much about masks, and that's such a simple device, but apparently so important and I believe your department has recommended that Manchester join many other New Hampshire municipalities and have a mask requirement, which hasn't happened at the city level yet, right?
Well, they just voted yesterday to highly recommend it.
Correct.
There's no teeth in it, but at least they've got a policy.
Yeah.
Okay.
So yeah, our Board of Health this summer recognized the value of face coverings, and while folks will debate the merits of efficacy, we do know that they are effective. In fact, CDC put out new guidance, which the state forwarded out as well, that further illustrated the benefits of face coverings for both the person wearing it and the people around them. You're right, it is a very simple way to do your part to help reduce the spread. It is not 100% effective. There's nothing that's 100% effective. But again, it's that layering and that coupling of all of those factors that is really going to give us a chance of keeping this at bay until the vaccine is readily available. And we can talk about that maybe in the next segment.
Yeah, let's do it.
But we do now, as of last night, have a face covering resolution that was passed by the Board of Mayor and Aldermen that is essentially the strongest recommendation to wear a face covering, but it does not have any penalties or anything of that nature.
Yeah.
It's more of an endorsement of the value of having face coverings, which our Board of Health, saw as important. Again, we think that's one more tool in our toolbox that is effective, and it's really just being a good neighbor and a good person to be mindful of others in that way.
Yeah. And the other thing that's very important in this is contact tracing. And yet I understand that at the state level, we're now saying we are just so overwhelmed now that we cannot actually do the contact tracing for everybody who's positive. It has to be prioritized to certain categories of people. Is that right? And how many people are involved in this contact tracing? Because I can well understand with the level of positives now that it's just a practical impossibility to do it for everybody that has a positive test. But what are you recommending and what are you doing in regard to pursuing contact tracing?
Sure. So yeah, we definitely follow the state's guidelines, on contact tracing. So we need to do now the protocol is to try to determine if somebody falls into certain priority groups, and those are defined as, and I might forget a couple, but anyone who's older than 65, because they tend to have poorer outcomes, and they may be living with other people that are of high risk. Anyone under the age of 18, because they are more likely to be in a school congregate setting, which could then ramp up a domino effect of impact. Those with special medical conditions or live in congregate settings, because we know that through previous experience that this virus can spread very quickly in any sort of dormitory, shelter environment, long-term care facility, medical facility, and also people that are disproportionately impacted by COVID. And so what we know is that in our data and state data, that persons of color tend to have a higher rate of infection per capita, if you will, or based on population than those who are Caucasian. And then we want to make sure that we are identifying ways to outreach to communities, and we've targeted some of our testing into the community. We have 2 drive-by mobile sites that we've been running since May, 2 days a week. Our testing is free, but we've also gone into the community and worked with faith-based organizations and other community partners like Manchester Housing Redevelopment Authority to meet folks of all walks of life to try to find out what their barriers are to getting testing and to bring the testing to them. So these are all groups that are for one reason or another either at higher risk or higher risk of complications. And so their priorities for when we get our lab reports, we do a screen, and then we try to get to those first. But we also are very thankful that our business partners and other city departments, and our school department's been a wonderful partner, because of the lag in case contact, tracing, but also sometimes the lag in rapid test laboratory information being absorbed into the state's electronic database. We are actually finding out from businesses when they have employees that say they've tested positive, sometimes before it's even available to us in our system. So we'll start investigations right off the bat for a restaurant, or schools or other venues. And I can't say enough about our partnership with the school district. The school nurses, as some people might know, actually work for the health department, and they are part of the fabric of the school community. And I've been very proud of the relationship between the district and our internal, our nursing staff and our internal nursing staff doing case contact investigations, because our nurses are sort of the conduit of information and really that liaison between the health department and families that are impacted by COVID. And even as a lot of families are remote and have been remote, we are still using our school nurses to follow up with families. And we also have a branch of the health department that's been working on supporting a hotline to answer COVID questions, to check in on families, to see if they have daily needs that aren't being met because someone might be quarantined. And we've worked with partners in the community and charitable organizations to have resources to help with food and rent payment and other things to help folks that are being impacted in that way. So it's a multi-pronged approach to contact tracing. It's not just call and check. It's what do you need for resources? What other impacts are happening? But yeah, to answer your question in a long-winded way, but to kind of circle back, is right now the caseloads across the state and all parts of the state are so impactful that we went from manageable to unmanageable in a very short period of time. And so we in our department, we are reallocating staff that serve completely different functions, and they've gone through the Johns Hopkins contact tracing course, and they're going to be repurposed. And I think I saw today that the governor was requesting the National Guard's assistance again, and they played a pivotal role in the initial surge, if you will, in that capacity.
Yeah.
So
getting out the PPE and that sort of thing.
Yeah, PPE. They actually did a lot of contact tracing, and they actually helped us set up our sort of intermediate hospital surge facility at Southern New Hampshire University. So, it's all hands on deck.
Yeah.
Well, gentlemen, we've gone a little bit long,
Let's
but
go
that was a
but
very
I think it would be a
comprehensive
good time
answer
to take a break.
to the question. But Brendan, if you could roll the B-roll, we'll take a little break, and we can plot our next segment.
I think we'll get on. November 18th. For the first time in the long history of the Progress Report, we're coming to you remotely via Skype. And we thank Brendan for helping us to set this up. And thank Mike for helping to set it up. And we thank our guest, Phil, for being our first guest on here as we're doing this. And Phil, what do you think of this? Should we be doing it this way? Should everybody be doing it this way? Or do you think it's okay to come into the studio with a guest or two for an hour?
So I think my answer is probably different than the last time we were together. I think given the circumstances, we sort of have flexed and unflexed and maybe reflexed some of our guidance. It's probably most prudent, given what's going on in the community, to err on the side of caution. And I'm honored to be your first virtual guest. I think I spend most of my time in the virtual world these days. So yeah. I think it's actually good that I think in a lot of ways we can actually make more time for getting together with people when it's less convenient to drive or you can fit people in. So I think it's prudent to try to do everything as virtually as you can while we're going through this
Yeah.
experience, and hopefully we can get back to, more personal contact sooner than later.
Of course,
Phil-
we'll look forward to that because then we can have public participation through call-ins too, which we're missing
Yeah.
today, and will be as long as we continue to do this. So, we've talked about the grim fact that you're in the red zone. You're meeting these metrics that require you to recommend the schools take action and all these things. But then we have the wonderful news that not one but two manufacturers come up with potentially very effective vaccines. And, I'm sure you're excited and pleased about that, as we all should be, because masks are fine, but it would be really nice to have this virus actually on the retreat.
I know.
In a fulsome way. So talk about this and how you will be helping our community to utilize these vaccines if, as we expect now and anticipate, they become available to us.
So thank you for introducing hopefully some positive news in the second half, so we can kind of trend in a happier direction. So yes, as you mentioned, there are several companies working on potential COVID vaccines. The two that have been in the news most recently are the Pfizer vaccine and the Moderna vaccine, and they both, on early indications, based on the data that the companies have provided, their efficacy is somewhere between 90 and 95%. I will say that either of these vaccines, if they receive approval from the FDA, which my understanding is that they may be ready to submit their emergency use authorization paperwork this week, they would both be a 2-shot series. So you would get a vaccination, and then you would have to come back in 21 days or 28 days, depending on the vaccine that you get. And so, it is very encouraging to see this early data, because there are many vaccines that do not rival this level of efficacy. If you think about the seasonal influenza vaccine, that is a little bit of an educated guess or gamble on what strains are going to be circulating, and you have 6 months to produce a vaccine, and things could change in that time. And with COVID, we've never made a COVID vaccine, so it is pretty unprecedented to have a vaccine go through trials so quickly. My understanding is that the technology used is a relatively new technology in terms of using messenger RNA. I don't want to go down the rabbit hole.
Oh, do it. Go down
yeah.
that road. It is fascinating. Instead of the old way where they would give you a weakened version of the virus, they're telling your body it's coming, get ready for it. It's a really, I would like you to get deep into that. Explain how that works.
So my understanding, and I may be a little bit off, my immunology is slightly rusty, but essentially they're tricking your body into making proteins that aren't going to make you sick, but are similar enough to the virus's proteins that your body will be able to know when it's coming and know what to do with it. So it is pretty fascinating, and it is if it works for COVID, because back in undergraduate and graduate school, it was we'll never have a cure for the common cold, but to have a vaccine for a coronavirus would be pretty amazing, given this technology, and I want to kind of delve into kind of the strategy for how the vaccine would be allocated, because this can be slightly unnerving when you have to make decisions about who gets something first. The good news is, I've spent a lot of time, and our department spent a lot of time, and others, planning for a smallpox attack or an anthrax scenario where you have hours to get medication or vaccine or antibiotics out to the public in a critical time period, and it becomes like an urgent matter of life and death. This is something that we want to think very carefully about how we allocate a limited resource to those who need it the most. And so the federal government has come up with a playbook, if you will, to try to determine what groups of people are either at the highest risk of contracting COVID based on what they do for work, and or who is most at risk of the worst outcomes. And so the state has a committee that's been working on thinking about this, and some of this will be the devil's in the details, but it'll be determined by how much we get and when we get it. And so the first phase would be a combination of healthcare high-risk workers, so those working in the health inpatient setting that are dealing directly with COVID patients. And our hospitals are planning to receive the vaccine directly from most likely one of the two vendors, and they're working in concert with the state, and then they will vaccinate their workforce. The first responder pool of people, so that's police, fire, and EMS, those are the folks that are most likely to come to you and treat you or come into very close contact with people that can't maintain 6 feet and can't, spend, less than 10 minutes with you. And they have the ability to spread it rapidly in the community if they weren't vaccinated. So the Manchester Health Department is part of the state's public health system. And there are 13 different regions of the state that have been planning for public health emergencies. And we've activated some of these response plans back in 2009 and 10 with H1N1. We've done work around hepatitis A vaccination most recently. So we've had some practice doing targeted clinics, whether it's a vaccine, whether it's antibiotics, depending on the scenario. So we have surveyed our neighboring towns, and in our region, Greater Manchester, we have a mix of urban, rural, and suburban. So we are partners with Auburn, Bedford, Candia, Deerfield, Goffstown, Hooksett, Manchester, New Boston. And so we're working with all of those towns to identify how many police, how many fire, how many EMS, as well as how many of your healthcare providers in those workforces are either paramedics or advanced EMTs, because the next phase of this operation will be heading out on the road and setting up clinics for those who either don't have a medical home, or we want to meet them where they're at. Maybe it's a residential complex where folks don't have transportation, or there's some other barrier to being vaccinated. So we're going to go out and and we've estimated it's just over 1,000 people. And we just got a mobile van, which will be able to take our show on the road. And we've also had a lot of practice during the COVID testing process to set up drive-through operations. So because we don't want to bring people into a big gymnasium where they could make each other sick potentially, we can do a drive-through model and set up different locations to do vaccination. And so these are all things that we're planning for. We've practiced to a certain degree. And so those two groups are kind of first up. The next group, which could also happen concurrently, is those who live in have very high comorbidity, or they have multiple comorbidities, meaning health risks, and they live in a congregate housing scenario, like a managed healthcare property, skilled nursing, long-term care, memory care, where they're at high risk because of their health, but also because of living communally. So all of the long-term care facilities in the state are being given a couple of options for how they're going to get their vaccine for staff and residents. Yeah. The first option is to partner with CVS and Walgreens, I believe, and they have national contracts, such that they will go to those facilities and vaccinate people on site.
Yeah.
We were planning on doing that, but we're we're thankful that that will happen so that we can focus on other vulnerable populations.
Yeah.
And so that's a really interesting public-private partnership,
Yeah.
and it really helps because they have the capacity to store the vaccine through their supply chains that
Yeah.
a lot of locals don't.
Yeah, you mentioned long-term care facilities, our nursing homes and congregate care. That was really the worst part of the first part of this virus being amongst us. Terrible losses there. Is that still the predominant, the most frequent source of these new positivities, or is it more widespread now?
So that's a great question. We're seeing the spread more broadly in the community. The long-term care facilities now have ongoing testing protocols to sort of try to identify anybody who could be positive, whether they're asymptomatic or symptomatic, such that they can quickly be isolated. So they've had to develop sort of ongoing surveillance. But mostly what we're seeing, the majority are not in those populations, and the state puts out a list of current outbreaks, and the number of long-term care facilities vis-a-vis the number of other types of clusters and outbreaks is not the predominant source of cases. So it really is community spread. Unfortunately, when you hear about fatalities, they do tend to be in those settings because of the health status and age of the residents.
And another thing we hear a lot about in the national news from places like, I don't know, Wisconsin and North Dakota and these places that are being, is that the healthcare facilities, I mean, the hospitals are being overwhelmed and really at the very cusp of being overburdened to the point where they'll have to, kind of triage care. Do we have any concerns of that sort of thing happening in our city with our two major hospitals or other healthcare facilities?
So I want to say that our healthcare partners, and we may have talked about this before, came together very quickly this spring and worked with the city health department, the fire department. Southern New Hampshire University was gracious enough to allow us to use their space to set up sort of that surge facility.
Yes, I remember.
And so, to the hospital's credit, they put a lot of time and effort into what that might look like, from patient transport to staffing to who goes to that facility under what conditions, and we worked through a lot of that back in the spring. The National Guard was instrumental in they were the glue in the operation. They really helped us with the logistics and the planning and the thought. We had I think I'm looking at some data from the spring and into May and June, where our city hospitals had upwards of 55 people with COVID in their hospitals. That was the highest. We are trending in the upward direction. We do know that there generally is a lag time between a spike in cases and when we see hospitalizations increase. It's
like a couple of weeks typically, right?
Yeah, exactly. And the hospitals, to their credit again, set up surge facilities within their facilities. So they converted units that could be repurposed for COVID, conference space. They really worked very hard because they felt, and I agree, it's better to have hospital level care somewhere on the hospital campus than it is to move it to a gymnasium or something like that, where you're kind of not connected to what you might need to step somebody up a level of acuity. So we conceived this alternate care site to be more of a step down lounge or a recovery area for folks that maybe needed observation after a surgery but were almost home, and then they could leave from there instead of taking up a bed where they needed them in the hospital. So the hospitals increased their capacity by at least, I think, 50+%. And we didn't get to the point where we came close to their internal surge numbers. So I'm fairly confident that the hospitals can surge within their own campuses again, and it just something that we monitor on a daily basis. So if we get anywhere close to them needing to activate their internal surge plan, we'll be ready to have that other facility at the ready.
Phil,
can switch.
we have a
Go ahead.
population. Excuse me, Bob. We have a population in Manchester. I think the number's around 360, 370, and I'm talking about the unsheltered population in Manchester. It's been an issue with the city. I'm not trying to go into a controversial area, but it is a fact of life here in Manchester that because of the services we offer and because of the way the city is set up, we have a rather large number of people who are living outdoors, and the living arrangements tend to be in a congregate kind of a situation. They're close together, and also they're very mobile within the community. So could you talk from a strictly healthcare perspective and relating to COVID, how does that impact the heat level here in Manchester? And given the winter's coming, there are other issues involved, health-related issues involved. Is there a plan in place to try to make things easier for those folks?
Sure. So I can talk a little bit about sort of the city's role in what we determined to be fatality prevention. Last winter, and this was pre-COVID, the numbers of folks that were experiencing homelessness had exceeded the amount of beds that were available at the emergency shelter in Manchester, and we started to see an uptick at that time. So we reached out to partners from other parts in the state that have opened additional cold weather surge facilities to learn about their process. How they have some training, operations, etc. We brought them in for a training. We trained volunteers in the community, faith-based volunteers and other affiliated volunteers. And we were fortunate enough to have one of our faith partners, Hope Tabernacle Church, step up to be a surge facility during that time. And so on extreme cold nights, that facility would be staffed by volunteers, and then folks that were going to Fit New Horizons would be directed to go to that location on those extreme nights for fatality prevention. And it had to be a process by which they checked in, because every interaction with someone is an opportunity to build trust. And the idea is the more interactions you have with folks that are experiencing homelessness and other comorbidities, the more likely they are to then seek the services that they need, so they can manage whatever their situation is and hopefully get into stable housing. So we operated the system operated about 20 nights last winter, and up to 22 extra beds at the surge facility. So that was about probably over 158 or 160 bed capacity in the system. Now that COVID has come about, the layout at Fit New Horizons needed to be modified to respect social distancing to prevent internal spread of COVID. And we did work with our partners at Fit New Horizons, as well as Healthcare for the Homeless, which is a partnership between the health department and CMC, Catholic Medical Center, to do COVID screening and testing in the shelter environment, because early on we heard people were fearful to be in a congregate setting with fears of contracting COVID. But we have healthcare embedded on that campus through Healthcare for the Homeless and rigorous screening that happens. And we've done subsequent testing in that environment, and we've had very few cases in the population served there, which has been a credit to their vigilance. But this winter, to your point, the numbers of people that we know are outside are much greater than they have been in past years. And so we've been working hard with all the partners in the sort of continuum of care around housing and homelessness to identify as many extra beds as possible. And so Fit New Horizons is converting some of their internal space from pantry space to additional beds. Partners like 1269 Cafe, which is a faith-based organization that has supported and those who are experiencing homelessness on many different levels, has purchased a property, and they are willing to help with cold weather surge to a certain degree. And then the city is working with partners as we speak to try to identify additional surge locations within the city to house people on those extreme cold nights, because we don't want people to die as a result of them being outside. And so, the fire chief and has been sort of at the front lines in the homeless encampments and really has a pulse on what's happening. And he's been leading the charge to make sure that we have safe options for folks as the weather gets very cold very quickly. And from a perspective around COVID, those experiencing homelessness and anybody else who lives in congregate living arrangements, as I mentioned before, are in sort of the second wave of the vaccine priority group, just because of the density of living. I'll also mention just briefly that another group that is in sort of that second tier, and it's more about how soon we get more vaccine. And as soon as we get it, we want to be poised to get it out to the next group that's at greater risk. As anybody who's involved in childcare and or school teacher and support services and administration, those folks are also in that higher tier group, so that we can make sure our critical infrastructure, broadly defined, is vaccinated, so that we have supports in place so that students can be educated in the best extent possible. And we all know that is in person, but right now, there are a lot of things pointing in a direction of being more cautious. And hopefully we can get folks to double down on prevention, and then, get the vaccine out as soon as we can get our hands on it.
Phil, we're almost out of time.
Okay.
You've given us a lot of great information. We really appreciate it. Just one other thing I wanted to touch on and go from hospitals to hospitality.
Mm-hmm.
We have a real concern about our restaurants and our performance venues like the Palace, and our hotels, of course. With the cold weather coming in and the lack of attractiveness for outdoor dining, are you working with these folks? I know one restaurant that I like to go to. I went in at one point they had lots of plastic dividers around, and the next time I went, it was gone. And somebody said, well, that would interfere with the air exchange, the ventilation. So what are you doing to help our struggling hospitality industry? Many of their problems they got to solve, you can't solve. But what advice are you offering?
So early on, we worked very quickly to help the hospitality industry operationalize outdoor seating plans that a lot of them had never taken on before. So we reviewed them all within a day of them submitting applications, and we looked at it from a COVID safety perspective. We provided them guidance on using the right disinfectants and what works and what doesn't, and employee screening. We've tried to do a better job putting stuff out on our website and Facebook and other means of delivering messaging. Our permit applications have an email address listed, and if people filled them out, we've been doing a better job e-blasting updates as they come in, and things change. And I think that's something that people don't like, and nobody likes change. But basically, the guidance will change because the nature of the virus evolves, and our understanding of what works and what doesn't evolve. So we're trying to put out updates to help coach people to do the right thing, because we'd rather people ask us before they are told that they can't do something, and they've invested in different things to improve their operation, it is a challenge. I mean, this is an indoor space, and it's not
With-
the
with
same
that,
as
we're coming up against it.
We're coming against the time limit. Phil, thank you so much. I know the long hours you're putting in, the hard work you're doing along with the other members of your department, and we really appreciate you taking time to come back and join us. It really is
very
very,
much.
very helpful.
Yeah,
Masks,
please,
folks, masks,
Yeah.
wear these masks.
and please
and,
support your
keep them
local
clean and,
community in any way you can.
Yep. Okay. Thank you so much for joining us. Thank you for those that tuned in. Thanks, Brendan, for the help. Thanks, Mike, for setting it up. And we'll see you next week with another edition of the Progress Report, which I expect will be the same Skype methodology.
Have
Take
a great
care,
week,
everybody.
folks.
Be well, everyone. Take care.